This part of the program is brought to you by St. Peter's Healthcare System, treating you better for life.
Welcome, listeners. You're listening to EBC Radio. This is 11:70 a.m. It's time once again for Heartbeat. I'm Dr. Dinesh Singal. I'm an interventional cardiologist. I'm the director of the catheterization laboratory at St. Peter's University Hospital and an attending cardiologist at Robert Wood Johnson and Princeton hospitals with offices in Somerset, Monroe, and East Brunswick. This program, for any new listeners, airs every second and fourth Saturday of the month on EBC Radio. It's an educational program about your health, so hopefully you enjoy and learn something from it. I'm going to be joined by my co-host, Dr. Meena Murthy. She's the Chief of Endocrinology at St. Peter's University Hospital. She's running a little behind, so she'll be joining us in a bit. Today's topic is something which is very important because as we grow older, the incidence of this problem increases. And we have in the studio today Dr. Maqsood Amjad. He is a cancer specialist. And we're going to have a discussion around colon cancer. And for our regular listeners, as you know, we not only will talk about the traditional diagnosis and management, but we'll also talk about how to prevent, how to screen, and help you kind of get a much better understanding, so we can avoid, these problems, and if they occur, to take care of them in a timely manner. The phone number in the studio is 732-297-9886, 732-297-9886. And we're also live on the web, www.ebcmusic.com. So, Dr. Amjad, thank you so much for joining us.
Thank you, Dinesh, for having me here.
Let's start with helping our listeners understand just the structure of the digestive tract. You know, we take it for granted. We're going to sit on a dining table, we're going to have a meal, and we kind of forget what all happens, or at least the path which that food travels, because that's going to be relevant to the rest of our discussion.
So before I start, Dinesh, I want to welcome and greetings to all the listeners. I'm Dr. Maqsood Amjad. I'm an oncologist at Regional Cancer Care Associates, which is a large private practice in New Jersey. And we call it RCCA. That's the abbreviation. And we treat cancers and blood disorders. And it is always our pleasure to share our insights with you. So, it's important before we start talking about colon cancer to just go over the intestinal tract. So we start from the mouth, where we ingest, place our food, and then food goes through several steps of mastication, and then goes into the esophagus, and then to the stomach, and then to the small intestine, which consists of duodenum, jejunum, and ileum. And then it ends into a large intestine. So we're going to focus more on the large intestine, but most of the nutrients in our food are absorbed and being utilized by our body, and most of this absorption of nutrient completes in the small intestine. The large intestine has 4 parts: the ascending colon, the transverse colon, the descending colon, and sigmoid colon, which then ends in the rectum and anus, where the waste materials exit. So the ascending colon has a pouch which is called cecum, and that's where the small intestine makes a junction with the large intestine. and the cecum ascends upward or travels upward. That's the ascending part of the colon. Then it makes a bend and goes from right to left. That's the transverse colon. And then it goes down from the left side all the way down, and that's the descending colon. And then it makes a junction with the sigmoid colon with the small S-shaped portion of the large bowel, and then it ends in rectum and anal area.
So, most of the once food is ingested, most of the role of digesting that food and absorption takes place in the stomach, small intestine. In the large intestine, other than it being a conduit, are there any other important role the large intestine plays as a food kind of the tail end of the food makes its way through?
So once the waste products are dumped into the cecal area and it moves further down into the tube, the main function of large intestine is to absorb water and electrolytes. And once all that is done, the waste material then has a small stay period in the rectal area. Because of the sphincter in the anal area, it doesn't get out without its relaxation.
So colon cancer is an illness which obviously occurs in the large intestine. Give us a sense of how frequently this problem occurs.
So colon cancer is third most common cancer in men and women in United States, and it's the third most common cause of death also in men and women. About 97,000 cases will be diagnosed in 2018 of colon cancer, and about 43,000 of the rectal cancer. They are lumped together as colorectal cancer, so 1.4 million cases will be diagnosed. And unfortunately, 50,000 people will die of colon cancer in 2018 based on the statistics.
So, are there certain patient populations which are more predisposed to this particular cancer? So, in other words, are there certain risk factors which predispose people to get colon cancer more often than others?
So the risk factors in colon cancer can be divided into two main categories. One is something we can change, and the other something we cannot change. So the things which we can change, I'm going to go over them very briefly, and then we can talk about those things which we cannot change. So things we can change is, one of them is obesity. Greater your body mass index is, more prone you are to colon cancer. Number two, physical activity. Less active you are, your chances of colon cancer are more. And there are nice graphs has been created for that based on the activity, the risk goes down and goes up. Then diet. In diet, the red meat, beef, pork, and liver, these kind of meat has been associated with high risk of colon cancer.
It's interesting you say all this. I'm a cardiologist. Dr. Murthy will be here soon. She's an endocrinologist. And it's so interesting that almost every conversation we have, with no matter what specialty we are discussing, it always boils down to at least some of these common things. Whether I'm talking to an orthopedic surgeon with back pain and knee pain, as a cardiologist, I see heart disease. So I just using those points, want to reinforce to everybody that a healthy life, there's no substitute to a healthy lifestyle. Being the right weight, exercising, and eating healthy. It prevents heart disease, diabetes, orthopedic issues, and now you're giving us a list for issues of colon cancer.
I cannot agree with you on that more. And by saying that, it doesn't mean that you cannot have a portion of any meat in your diet. Is the moderation. You cannot have excessive. Having small portion once a week probably will be adequate. And also the processed meats, which are, has been flooded in our market or have been linked to the colon cancer. The meat which is cooked at very high heat, grilling and frying, all those meats can sometimes also have higher incidence.
So I know you, and I. You kind of, our discussion today is colon cancer, so you're talking from that perspective, but just from a cardiovascular perspective, data shows that people who have a largely plant-based diet have a much less incidence of heart disease. So when I sit with patients, I advocate to stay away completely. Obviously, it's hard when people have been doing things differently. I just want to kind of throw it in there.
That's good. So in addition to these dietary risk factors, then smoking has been linked to colon cancer like many other cancers. Alcohol, drinking in excessive amounts, again. And if you look at these things, as Dr. Singal said, these dietary issues, the alcohol, smoking, they has been associated with not only cancer, a lot of other diseases, especially the cardiovascular diseases. And in the factors which are fixed factors, then we come to the age. Older you are, the higher risk of having colon cancer. If you have a personal history of colon cancer, or if you have personal history of having multiple or large polyps, especially the adenomatous polyps, your risk of cancer is high. If you have inflammatory bowel disease like Crohn's disease or ulcerative colitis, these patients have higher risk of colon cancer, and it increases as the number of years goes by. So after 30 years of having such disorders, your risk goes up to like 30%. Then having family history of colon cancer, especially in the first degree relatives, or if someone has cancer in age less than 45, the risk is tremendously high. And then we have the inherited syndromes like Lynch syndrome and familiar adenomatous polyposis syndrome, we call FAP. Having those inherited syndromes can they only contribute to 5% of the colon cancers, but if you have those syndromes, the risk of colon cancer is in the range of 80 to 100% based on which syndrome you have. And then the ethnicity plays a role. The colon cancer is high in African American population, is high in the Ashkenazi Jews, Jews of the Eastern Europe descent. And also type 2 diabetes has been linked with colon cancer, but it may be because they share the risk factors also. So these are the main risk factors. In addition, I would say if someone has been treated before for any cancer or have radiation to the pelvic area, the incidence of cancer also goes up in those populations.
You're listening to EBC Radio. This is 1170 AM. I'm Dr. Dinesh Singal. We're talking to Dr. Maqsood Amjad. He is a member of the regional cancer group here, and he joins us to discuss colon cancer. Again, the phone number in the studio is 732-297-9886. So we have a sense of who is more likely to have cancer. Obviously, not everybody who has those issues is going to have cancer. The first step in any medical problem is to figure out a way to prevent it, but also to detect it much earlier, because as we all know, cancer, the earlier it's treated, the better off one would be. So when you are looking at colon cancer, what are some of the tools which are available to screen people so we can pick it up much earlier than when they typically would come to you with an obvious diagnosis?
So I think before we talk about what we call screening or how to detect it early, it's important to know how the colon cancer occurs. So the colon cancer starts in a very small growth from the mucosa, from the inner lining of the colon. And those growths, we call them polyps. These polyps are of two types mainly. One is adenomatous polyps, and these are the polyps, some of which can change into cancer, and we call them precancerous polyps. The other kind of polyps are hyperplastic polyps. They are usually benign and does not change into cancer. So it's important to detect these polyps, and if we can take them out, the cancer risk will be not only goes down, but also it can be curable also. So there are two main kind of screening tools we have. I will divide them into stool-based tests and the visual test. So the stool-based tests consist of three kind of tests which we have available today. The first one is called fecal immunochemistry test. We call it FIT, F-I-T. It's a highly sensitive test, and basically the stool is checked for immunohistochemical. It's a immunohistochemical assay and detect the cancer cells there.
So this is a sample which is given to a lab, and then the lab sends it out?
Yes, that's correct. The second kind of test is which we many times do in offices. It's called GOIC-based fecal occult blood test. We call it GFOBT. It's a highly sensitive test, and detection of blood then leads to further testing, which can be used to detect the cancer.
Does one of them come up positives earlier than the other between the two tests you just mentioned?
They're done in different ways. The second test is basically just looking for blood in the stools. The other one is more immunochemical test and detect the blood and cells, from which cells which are shed in there.
So I guess my question is it possible that the FIT test comes back abnormal while you may not pick up actual blood on the GOIC test?
Yes, that's true.
Okay.
And these tests are repeated, both of them once a year, from age 45 to 75, I would say. And then the third stool-based test is something we call Cologuard, which is a multi-targeted stool DNA based test. And basically this test detects any changes in the DNA and is almost 92% sensitive. There are still some false positive tests which then lead to unnecessary colonoscopic exam, but still it's a quite sensitive test.
So again, it's a stool sample which is sent for evaluation?
No, this is a special test which you can you will be require prescription for that. Then it will be sent to your home, and you use your stool and send it back, and they will look at those analysis and give you the results.
So which kind of an individual? It looks like it's. Is it a little bit more involved than the other two? The FIT and the stool GOIC?
That's correct. This is one of the most recent one, and probably more sensitive to detect cancer cells.
So how do you decide which person should have the Cologuard versus the other two, which are simpler and faster to do?
So there are no hard and very stern guidelines in terms of what is the best test. I think more important is that some kind of tests or screening tests should be done, and that will lead to a cascade of other things which can lead to early detection of the cancer. So, of course, the FIT and GOIC FOBT are easy to do. They are quick tests. There may be some cost to the Cologuard test, and it's done in those patients who have a standard risk for colon cancer. This test is not recommended in those patients who have high risk of colon cancer, like personal history, family history, or other risk factors we mentioned.
And in most instances, it's either the internist or the gastroenterologist. So generally, these tests are getting done by those specialists,
That's
right?
Correct.
You probably will see these patients only once a diagnosis has been made.
That's correct. Right. That as a general rule, oncologists see these people after the diagnosis is made.
Sure.
And these tests are mostly done or recommended by the internists, family practitioners, and sometimes even gynecologists, because they are primary physician for many women, and also by the gastroenterologist. And then we go to the visual screening tests, which again are three kinds mainly at this time. One of them is flex sigmoidoscopy, the colonoscopy, and something we call CT colonography or virtual colonoscopy. And there are some plus and minuses about each kind of test. Again, the colonoscopy will detect, any growths in the whole colon, and if it doesn't show any polyps, then it can be extended to every 10 years. If it does show polyp based on the number of polyps, size of polyp, then the gastroenterologist will decide if you need another colonoscopy in 3 years, in less time, or slightly more time. The CT colonography Again, it's quite sensitive to detect a growth, but it's still not alternative for colonoscopy, because if you find a growth, then you have to end up in having colonoscopy. And if it's negative, it can be repeated every 5 years during the age which is mainly described for the screening time. And the flex sigmoidoscopy, again, is a test where you don't have to look at the whole colon, but it can detect quite a number of cancers just by looking at the lower part of the colon in the sigmoid and surrounding area. It's easy to do. It can be done in the office. Many times you don't need anesthesia. Again, the drawback is you cannot look at the whole colon, and this also need to be repeated every 5 years.
So I think the important point to make is that as one is getting older, these tests are almost imperative if one wants to pick this cancer at an early stage, and colonoscopies at certain intervals. And, folks don't have to remember as they're listening. The important thing is to ensure that that gets done, and when your physician recommends it, to follow through. I see a lot of patients. I don't deal with it on a regular basis, but I know that there is a degree of resistance to getting a routine colonoscopy every so often. As you will discuss with us later, once colon cancer steps in, obviously not every situation is bad, but it's involved when all different kinds of treatment modalities come in, and as you pointed out, people die. So not only a healthy lifestyle is important, but all the things you mentioned in terms of screening are options available to us to minimize our risk for a major problem down the road.
I cannot emphasize it more, Dinesh, that the main message what we're trying to give out is that one must go for screening. This is life-saving. This is not even early detection. It can be curative, because once a cancerous polyp is removed, you're cured of the cancer. And if it's not removed, it will get into the inner wall of the colon and then to the middle wall where muscular wall where the blood vessels and lymphatics are present, and the risk of spreading outside and the cancer becoming incurable can be high. So it is extremely important that one must go for screening. If I know the resistance and the shyness to go for colonoscopy, but if it's of that nature, at least you should go for the other kind of screening tests available, and colonoscopy then be performed if you need it. But it is extremely important that everyone after the age of 45 or 50 should look for a screening test.
And I just want you to reinforce the point that you do see patients who are diagnosed early, and they can be fully cured of the problem. So I'm posing this as a comment and a question, so you can respond to that.
Yes, a cancer which is found in the polyp is almost 100% curable. You are cured before it goes into the wall of the colon. Once it is in the wall of the colon or gets outside into the lymph nodes, as long as it's not spread to other areas, still is considered it has a potential of cure, and that's extremely important thing that even if it gets to stage 3, still we can cure half the patient with additional measurements. But once it is a metastatic cancer, it goes beyond the lymph nodes into the distant organs. It is essentially considered an incurable cancer.
You're listening to EBC Radio. This is 1170 AM. I'm Dr. Dinesh Singal. We're talking to Dr. Maqsood Amjad. He is a member of the Regional Cancer Care Associates. He's an oncologist, specializes in cancer, and our topic today was colon cancer. The first half of the show just flew by. We'll be back right after this commercial break. If you have any questions after the break, the phone number in the studio is 732-297-9886. Just as a reminder, old copies of the show are available on heartbeatradioshow.com.
EBC Radio would like to thank St. Peter's Healthcare System, treating you better for life, for sponsoring the preceding program of Heartbeat Show.
We know finding a good doctor, someone you can trust, is not easy. But now you can find St. Peter's Physician Associates, a network of primary care doctors and specialists, at Fairways Town Center on Stelton Road in Piscataway, offering evening, weekend, and walk-in hours. To book an appointment online, visit sppanj.com or call 732-339-7575, 732-339-7575.
This part of the program is brought to you by St. Peter's Healthcare System, treating you better for life.
You're listening to EBC Radio. This is 1170 AM. The show is Heartbeat. It's an educational program about your health, which airs on EBC Radio every second and fourth Saturday of the month. We're glad you're joining us and hopefully enjoy and learn from the program. I'm Dr. Dinesh Singal. I'm an interventional cardiologist. I'm joined by my co-host, Dr. Meena Murthy. She is an endocrinologist. And today in the studio, we have Dr. Maqsood Amjad. He is an oncologist, a cancer specialist, who is part of the Regional Cancer Care Associates. It's a large oncology group in New Jersey. And our topic today has been colon cancer. We discussed in the first half who is more prone to get it, what kind of tests can be done to do screening, and the importance of that screening, because this can be a curable problem. Otherwise, it leads to a lot of issues, and we're going to talk about that in the second half. The phone number in the studio is 732-297-9886, 732-297-9886. If you have comments, you want to share something with us, or if you were someone who did do the screening and had an early detection and therefore were cured, and it might encourage other people to go get that test done, feel free to give us a call, 732-297-9886. So, Meena?
Yeah, I was listening like other listeners on the way here. It was a great summary of how to screen for colon cancer. I had a question for Dr. Amjad. So if the Cologuard test is negative, do we still go ahead with other screening? Is that necessary, or could we just rely on that?
So Cologuard test is about 92% sensitive, meaning it can detect colon cancers in that number of patients. But still, there are, like any other test, there are false positives and false negatives. False positive mean you don't have cancer, but the test is positive. So patients will undergo further testing like colonoscopy and may not have cancer. And again, there are some false negatives also. In general, if Cologuard is negative, I think you can safely continue to do the screening every three years. That's the recommendations.
So you still need a colonoscopy?
If it's positive.
All right. Okay.
Well, so let's move on to what kind of symptoms will a person present. So we've gone past screening. So someone now has colon cancer. Obviously, they don't know that right now. What kind of symptoms, what kind of things a patient will notice or individual will notice which will prompt them to get the workup and you come up with a diagnosis?
So colon cancer can present in a variety of ways. It is possible that patient may not have any symptoms, and sometimes the colon cancer is diagnosed incidentally. One example is that sometimes we do PET-CT scans for other reasons, and we see a hot spot in the colon where there's significant uptake. We send patients for colonoscopy, and we find they have cancer. In other cases, on a routine kind of colonoscopy, sometimes patients are found to have cancer, so they may not have any symptoms. The most common symptoms are change in bowel habits, so any change which continue for more than few days is important, such as patients can have alternating diarrhea, constipation. They can have change in the caliber of their stool. Sometimes we call them pencil stools. They can have sometimes a hesitancy, a feeling that they have not emptied out well. So all these, any change in bowel habits at least should prompt to do some kind of testing.
And the reason that's happening is because you have a mass or a growth, and that growth is impacting the flow of that so-called waste material we talked about earlier, and resulting in some of the things you just described, right?
That's correct.
Right.
That's correct. And then one of these signs can be a blood in the stools, which sometimes is detected if you are anemic. Your doctors may check you for blood in the stools. You can have bright red blood per rectum, which is more so in the rectal cancers, but it can happen in the low-lying colon cancers also. Patients can have weight loss due to this cancer growing, and with the many chemicals being secreted in the body, patients can have weight loss. Patients can present with the loss of appetite. They can present with extreme weakness and tiredness, which many times is related to the anemia, the underlying anemia which they develop due to continuous loss of small amounts of blood. And this anemia in general is microcytic, which means that the size of the red cells is smaller, and that signifies patients with iron deficiency due to the loss of blood. And also patients can present with crampy abdominal pains many times based on the location of the tumor.
So what you described is a whole host of symptoms, right from having no symptoms with this condition to presenting with a very advanced stage where this probably has been lingering on for some time. But
I think to caution the listeners, the reason we screen for this is because most people have no symptoms, and by the time symptoms present, it may have significantly advanced, and we want to find it early, right?
You said it very, very well, and that is the most important thing, that when symptoms happen, in general, your cancer is growing somewhere, maybe still in the early stages and can be cured, but any signs and symptoms tells us that your cancer is on the way of growth.
So someone who was not getting screening starts having, or wasn't picked up for whatever reason, now starts having symptoms, change of bowel habits, they have blood in the stools. What should those people do?
So those people have to contact their primary doctors as soon as possible. The primary doctor most likely will do some blood test to detect if patient has anemia, and based on the symptoms, such as if there is change in the caliber of stools or if there's any abdominal pain, we'll send to a gastroenterologist for colonoscopy or for scans based on the symptoms.
And then the gastroenterologist typically will do some further testing, and one of the common ones would be a colonoscopy we talked about, largely to get he may do CAT scans and another test, but the goal is to get a piece of tissue to make the diagnosis.
That's correct. When the symptoms happen, then it's not screening anymore, then it's evaluation and diagnosis. So in those cases, the most likely the gastroenterologist will do a colonoscopy, and if needed, patient will be sent for scans to make sure there's no other disease anywhere outside. Can these symptoms always mean cancer? I would say no, not always, but the likelihood of having some problem in the colon is very high.
So the purpose of that test at that point is, one, to make the diagnosis that there's cancer, and the other test you suggested is to, once that diagnosis is made, to see the extent of the problem.
That's correct. That's basically called staging, that if you are diagnosed with colon cancer, next step we have to do is to know the extent of disease to see, to not only determine the prognosis, but also the treatment.
So the most direct way to, find the diagnosis is colonoscopy, taking a little tissue biopsy and looking at it under the microscope. And taking a shortcut to that is not always wise, and people sometimes sit on a problem for a while because they don't want to have a colonoscopy. So I just wanted to maybe emphasize that.
So, without getting into too much technicalities, if you can, in some layman's word, describe to us the various stages. You referred to the word stages, and that comes true with any cancer. And again, it depends on where all it's spread. So just to give folks a feel when you're looking at these stages, what all it means.
So when we talk about staging, the traditional way to tell about staging is stage 1, 2, 3, 4. And that's the easy to understand and more patient-friendly and public-friendly kind of staging. Although in more sophisticated way, now we look at the T-N-M staging, where T stands for tumor size, N for the involvement of lymph nodes, and M as a distant metastatic disease or spread of the tumor. So if you can imagine the colon as a tube, when you take a cut out of that, there will be an inner lining which is called mucosa. That's where the cancer originates. And then there will be a wall of the colon which is made up of connective tissue and muscles and blood vessels and lymphatics. And then there is an outer lining called serosa. So these are the layers of the colon. And then outside serosa is other organs or lymph nodes. So if a cancer cell is still present on the inner side of the lining in the mucosal layer, it will be called stage 1. And if it's in the wall of the colon, then it's stage 2. And once it goes spread through the lymphatics into the outside draining lymph nodes, it becomes stage 3. And if a disease spreads to a distant organ like liver, bones, lungs, brain, or any other further area, then it's a stage 4. And basically these staging provides us a good understanding of the prognosis, that how patient is going to do in the future.
From the time someone may have the inception of cancer, what's the time frame from that point that it makes its way through all these different layers?
So it is hard to answer that question in just one sentence. It depends a lot on the biology of the cancer. So we all know that certain cancers behave very aggressively. In that case, they can spread within weeks to months. And the other cancers can be very, very slow growing, which is the general rule. So in order for some cancer to start from the polyp and reaches to outside needs a few years.
So not all colon cancers have the same underlying pathology, in the sense that the nature of those cells can vary from one person to another.
That's correct.
You're listening to Heartbeat. This is EBC Radio. I'm Dr. Dinesh Singal with Dr. Meena Murthy. We're talking to Dr. Maqsood Amjad. He is a cancer specialist, and our topic today is colon cancer. Again, our phone number in the studio is 732-297-9886. So once you know what that stage is, well, actually, let me ask it this way. What is the relevance from your vantage point, and how do you explain to the patient the importance of whatever you figure out is a stage? Why is it important to know the stage?
So the staging evaluation comes after you have done a tissue diagnosis, and after you have gone through the clinical staging first. Clinical staging means something which you can tell without looking at the whole resected specimen of that colon area. So, for example, if colonoscopy is done and the cancer is inside lining, and we did the CT scans and we don't see anything outside, most likely this is stage 1 or stage 2 cancer. But in the end of these investigations, the patient has to go for surgery. And once you do surgery, you resect that portion of the colon, and then you look at under microscope in great details, looking at the extent of the cancer, whether it has been in the wall of the colon, whether it has been gone through all the layers of the colon wall, whether it is in the lymph node, and that determines how one should proceed. So if the colon cancer is within the wall of the colon, it is stage 1. Or if it is only in the inner wall, those patients are essentially, majority of them will be cured just by the surgery, and they don't need any additional treatment for the colon cancer to protect them from its recurrence. If the cancer has gone into the lymph nodes, in addition to the surgery, all those patients will need additional treatment, what we call adjuvant treatment, meaning as an adjunct to the definitive treatment, which is already done. And the main purpose is to decrease their risk of recurrence and save them from having a recurrence of the cancer, which can then spread to other areas. Those patients may need additional treatment with the chemotherapy, which are the sometimes intravenous drugs, and sometimes they are oral pills or combination. And if by the scans, this is a metastatic cancer, it has spread to the liver, these patients are now not curable, and the goal of treatment is totally different. In those patients, we like to control the disease to provide best quality of their best quality of life, and at the same time trying to extend the longevity.
So when when the gastroenterologist makes the diagnosis, the patient will see an oncologist who is the cancer specialist, and invariably will need a surgeon, right, who is specialized in colorectal surgery many times, and different levels of surgery are done, right? Sometimes the whole colon is removed, sometimes part of the colon is removed. How are those decisions made?
So any cancer in today's time is a multidisciplinary approach is must. What it means is that right from the beginning to the end, we involve all the stakeholders. So in this case, primary physician, the gastroenterologist, the oncologist, and in some situation, radiation oncologist and colorectal surgeons. So these will be a team in addition to many other ancillary and supportive people who will be part of this team, like nutritionist, genetic counselor, and navigator. So these are all makes a team. It makes the experience better and provide a better quality of care. So going back to your question, so if it's a standard risk patient and you find a cancer in one area of the colon, the surgeon will evaluate after the initial testing, diagnosis, confirmation of pathology. And in general, these surgeries in today's times are done laparoscopically, meaning a small incisions are made, and the inside procedures takes place with the help of small tubes and instrumentation like cameras. And that portion of the colon will be, with clear margin, will be resected from both sides, and it will be taken out, and rest of the bowel will be attached to each other. We call it anastomosis. So this is the general kind of procedure which most of the patient with colon cancer will have. There are certain exceptions. So if patient has a cancer which is in the rectal area, that's considered a different treatment for that kind of cancer. So in that case, if the tumor is diagnosed initially, the gastroenterologist will do an endoscopic ultrasound to look at the extent of the tumor, whether it's going into the whole wall of the rectum or lymph nodes, and based on that, the patients most likely will need an neoadjuvant treatment. Neoadjuvant means something given before the definitive treatment. So in this case, patients get chemo and radiation before doing definitive surgery. There are some patients which has inherited syndrome, hereditary risk, risk such as Lynch syndrome or familiar adenomatous polyposis syndrome. So those represent about 5% of the cancers. So especially the familial adenomatous polyposis syndrome only makes about 1% of the cancer. But the importance is that these patients will develop. There's 100% chance of getting the colorectal cancers. And these patients start having polyp growths at the age of 10 to 20 and by 10 to 12. And at age 20, one or more of these these polyps will grow into cancer. So these patients need to be looked at very early in their life, and many times the total colectomy from all the colon from top to bottom need to be removed, and still sometimes the risk does not go to zero in these patients, because you always leave smaller, even if you leave smaller portion of colon, that can cause cancer.
We recognize that as the stages are progressing, it is a more serious form of the cancer. But when you talk to a patient and you tell them that this is your stage, can you kind of walk us through what you tell them in terms of what they should expect in terms of longevity? You said a lot of this is the third leading cause of death in patients. So when you're talking to them, what kind of frame of reference are you giving them?
Right. So this is the third most common cause of death in men and women together. But good thing which I have to share is that in last 3 decades, the risk of deaths has been going down, and it's primarily we think is due to the early detection and curing by removing the polyps. So again, it comes back to the same basic kind of message we want to give, that the screening is must for everyone who is in that risk group or in that age group. Saying that, of course, patients most of the time are quite educated. They come to us many times after looking and researching on these things, and they understand that the more advanced the staging is, more chances of their recurrence are. So in a patient who has stage 1 cancer, their risk of getting any recurrence is 5 to 10% in that range. So it is they of course get extremely satisfied, but at the same time it does not necessitate continued follow-up for the rest of their life because of that still risk of cancer recurrence. Not only cancer recurrence, anyone who has personal history of colon cancer always have high risk of developing another colon cancer. So these patients have to be even more cognizant of this screening and continued follow-up.
But between the fact that it was detected early and that they'll be hopefully more vigilant, they can hopefully expect a normal lifespan.
That's correct.
Right.
That's correct. That's correct. There is a high rate of cure in those patients, and after the treatment is only surgery, which sometimes can change some bowel habits, sometimes only for a short period of time, but in general they live normal life. Patients who have stage 3 disease, meaning when the cancer moves to the lymph nodes, surrounding lymph nodes, the risk of recurrence goes more than 50%, and risk of recurrence is more the more the lymph nodes are involved. So as a part of the surgery guidelines are that we have to remove at least more than 12 lymph nodes from their surgery site. And in today's time, most of the colorectal surgeons are extremely trained in this, and they remove almost even double that number of lymph nodes. So having one lymph node out of let's say 25 lymph node positivity has much less risk of recurrence as compared to someone having 7 lymph node positive out of 25 lymph node. And in those patients, they definitely need additional adjuvant treatment with the chemotherapy. So chemotherapy is never a pleasant word for any patient, but as an oncologist, we make sure with our team of experts, our team of our support group around us, we make it a much better experience for them, and we try to make sure they don't have any long-term toxicity, and they get through this unpleasant treatment, in a much better way. And in those patients, still the risk of recurrence remains quite high, so they are also followed very religiously. In patients who have stage 2 disease, that's still considered a gray area. There are no stern guidelines except in those patients who show a high-risk disease, such as they present with perforation, they present with obstruction, or if they have some genetically important histology on their cancer.
Well, before we realize the whole hour is over, and I would like to thank Dr. Maqsood Amjad to give us a great overview of colon cancer, right from who gets it to how to screen for it, how to diagnose it, and kind of an overview of management. But I think the message from all of us here is that a healthy lifestyle, there is no substitute to that.
EBC Radio would like to thank St. Peter's Healthcare System, treating you better for life, for sponsoring the preceding program of Heartbeat Show.